Good afternoon, everyone. Happy Independence Day to everyone, and thank you for taking out time today to attend this webinar. So the topic that we have chosen today is the combination of tuberculosis and liver disease. The reason why we have selected this topic is because tuberculosis is endemic in India, and the association between tuberculosis and liver is, I would say, underrated, underappreciated. And it is time we all understand the significance of the relationship between the two organs and the disease and the liver as well. So to start off my talk, I think I'll discuss 4 issues of tuberculosis and liver. The first issue would be hepatic involvement in tuberculosis. So when TB affects the liver per se, what are the different types? Does it affect? What are the symptoms? I'll discuss. The second topic that I'll be discussing would be how does tuberculosis medicine affect the liver? So that is anti-tuberculosis treatment affecting the liver, causing drug-induced liver injury. The third topic that I'll discuss is those who are suffering from liver disease. Now, can they develop tuberculosis? I think they can. And what is the difference from routine tuberculosis in diagnosis and treatment that I will discuss. And just to complete the talk, I'll add a couple of slides on tuberculosis in patients of liver transplant. What is the significance of developing tuberculosis when the patient is actually being evaluated for liver transplant, as well as when the patients develop tuberculosis after liver transplant. So I'll start off with my first topic would be hepatic involvement in tuberculosis. So per se, hepatic involvement in tuberculosis is quite uncommon. If we see, less than 1% of all tubercular infections is actually causing liver injury. But the reason why it is assumed is because of low tissue oxygen tension in the liver, and that leads to less involvement of tuberculosis in liver. But if we carry out anatomic assessment after death of patients suffering from tuberculosis, if we see, then 25% of those suffering from pulmonary tuberculosis have liver involvement, and those having extrapulmonary tuberculosis, even 80% of those having involvement of liver. So how does tuberculosis affect the liver? So if we see, the involvement by tuberculosis into the liver could be either diffuse or localized. So if there is diffuse involvement, it can be either a part of systemic disease, that is miliary tuberculosis, or it could be an isolated diffuse involvement of liver, and that is tuberculous hepatitis. Or there may be sometimes localized involvement, that we call it as hepatobiliary tuberculosis. And that localized involvement can be in form of abscess, tuberculomas, or sometimes as bile duct involvement. Now, if we look at Indian data, this is published from Mumbai, that what was the involvement of hepatobiliary tuberculosis in a study where they saw 280 patients. Out of this, 58 had hepatobiliary involvement. Of those 58 with hepatobiliary involvement, isolated hepatobiliary involvement was seen in 38 cases. And of those 38 cases, 15 had biliary tuberculosis, 20 had hepatic tuberculosis, and the 3 remaining had combination of the 2. So if we go into detail of this, so hepatic tuberculosis, if we see hepatic tuberculosis, diffuse granulomatous hepatitis was seen in 25% of cases, or a localized was seen in nearly 25% of cases. Biliary tuberculosis, if we see biliary strictures in 5.2%, gallbladder involvement in 2.6%, but the most common involvement that we routinely see is presence of a periportal lymph node mass that is causing biliary obstruction, and that is seen in 35% of cases. The mixed any combination of the above can be there. So how does TB enter into the liver? So tuberculosis enters into the liver either from the portal vein or from the hepatic artery. But if it enters from the portal vein, the chances of it being a focal or a localized tuberculosis are higher. While it enters from a hepatic artery, the chances of a diffuse involvement is higher, that is granulomatous or a miliary tuberculosis. But whatever may be the route of entry or a portal of entry, once it enters into the liver, they get out into the portal system, and that start forming granuloma in zone 1. So zone 1 is usually periportal region. How does this tuberculosis present? So any tuberculosis presents in a similar way, like fever, weight loss, anorexia. If it's a part of miliary tuberculosis, then respiratory symptoms predominate. But if we say per se the abdominal symptoms, it is abdominal pain or can be splenomegaly or ascites. The question that we would all like to ask is jaundice a presenting symptom for hepatic tuberculosis? Now let's look into what the data says. If we look at this data published in 2015 from all the studies which were incorporated, what were the clinical presentations? So hepatomegaly was seen in 80%, fever 70%, respiratory symptom nearly 70%, abdominal pain 60%, loss of weight 60%, splenomegaly slightly rare 30%, ascites nearly 25%, but jaundice was there in 20% of the cases. So if we compare in the data, Indian data where hepatic TB and biliary TB were there, so why does jaundice occur? So if we look at this chart, the presence of jaundice in hepatic tuberculosis is not there. It is 0%. The presence of jaundice was there in biliary tuberculosis. And as I said, the most common reason of presentation would be biliary obstruction caused by the lymph node mass leading to obstructive jaundice and development of jaundice. So the jaundice is not usually seen when there is isolated liver involvement, but jaundice is seen when there is biliary system is involved. Otherwise, if we see the fever, weight loss, jaundice, itching, abdominal pain, hepatomegaly, splenomegaly, rise in bilirubin, the same jaundice, enzyme elevation between the two, alkaline phosphatase and GGTP elevated. There are some unusual presentations of hepatic tuberculosis as well. And I think one of the evaluation tests for pyrexia of unknown origin is CT abdomen. And if does not respond, if you are not able to find out, then it is a PET CT. So this is a classic example of it. A person having a pyrexia of unknown origin, they got a CT abdomen done. The CT abdomen does not show anything. As a later part, they underwent a PET CT and you can see that there is some activity in the liver. And this was biopsied under a CT guided biopsy, and that showed a hepatic tuberculosis on histopathology. Sometimes the primary hepatic tuberculosis can even present as acute liver failure, though it is quite rare, but there are case reports where tuberculosis has caused acute liver failure. The classical example of granuloma and AFB bacilli. TB can also present as liver abscess. As I said, that localized tuberculosis can present as liver abscess. And if we see the difference between anybody who's presenting with liver abscess, whether it's a tuberculous liver abscess or non-tubercular liver abscess, we cannot differentiate on the basis of clinical symptoms. The clinical symptoms are exactly similar between the two groups. If we again see in the case, jaundice not seen in the tubercular group. So liver abscess, isolated liver involvement causing jaundice is not there. And even in the investigation part, I don't think that anything was there to differentiate between the two. So they usually require a biopsy. So what are the investigations where you need to do when you are suspecting a hepatic tuberculosis? I think in sometimes an ultrasound would show, the image on the left shows focal calcification, scattered calcification. Even in a CT, plain CT, we are seeing the scattered calcification. This is a sign of tuberculosis. If there are focal lesions, if you see on the plain CT, there are calcified nodules are there. On an arterial CT, if you see there is haloing is there. So this is classical of edema. So focal, and this needs a biopsy confirmation to prove whether it is tuberculosis or something else. Sometimes they present as a appearance of a malignancy. So if we see the CT, the liver is showing a mass on the CT scan as well as an MRI. Biopsy was done which confirmed it to be tuberculosis, and after a conservative medical management, if we see the last image, there is complete resolution. So it can even present as a mass. This is a feature where this CT scan is classical that we see in cholangiocarcinoma. So a patient was suspected to have cholangiocarcinoma, underwent a resection, and on resection caseating necrosis was found and tuberculosis was there. So this is presenting of tuberculosis as similar, mimicking as cholangiocarcinoma. But again, as I said, the most common presentation is presence of multiple lymph nodes. So these asterisks are showing lymph nodes, and these lymph nodes can be easily biopsied by endoscopic ultrasound. And once we biopsy we tend to see AFP in culture or gene expert, and then we start them on anti-tubercular treatment. So how to diagnose? So the diagnostic imaging would be a chest X-ray to rule out pulmonary involvement, an ultrasound, a CT scan, and for a localized disease, a liver biopsy, which from the liver biopsy, we need to do an AFP smear or an histopathology or a PCR analysis. There are diagnostic criteria which are recommended in 2014, but I would not go into detail of it. Each one recommends that ideally you should document the bacilli before starting ATT. Just to end this topic of hepatic tuberculosis, there are two types, that is diffuse involvement or localized involvement. Diffuse involvement or miliary tuberculosis is much more common, where the primary origin is lungs. It comes from hepatic artery. There are multiple small sized tubercular nodules into the liver. Patient has clinical symptoms of respiratory system, much more common. CT scan would give us a diagnosis, and the treatment remains the same, the 4-drug regimen that we routinely give. There is no difference in the treatment of hepatic tuberculosis from any other tuberculosis. Localized, the involvement is via portal vein, and liver biopsy is needed in those cases to document tuberculosis. The treatment again remains the same, 4-drug AKT, and sometimes if the abscess is large, they need a percutaneous drainage as well. So coming to my next topic would be anti-tuberculous treatment affecting the liver, that is drug-induced liver injury. We call it as DILI. So when we call drug-induced liver injury, it is the classification of drug-induced liver injury is intrinsic or idiosyncratic. Any idiosyncratic can be metabolic or immunoallergic. So the type of drug-induced liver injury caused by ATT is usually idiosyncratic drug-induced liver injury. So how do you define it? It's an adverse hepatic reaction that is expected on the basis of the pharmacological action of the drug administered. And there are classification of this injury could be hepatocellular, cholestatic, mixed, or chronic. So if ALT is predominantly elevated, it is hepatocellular pattern. If ALP is predominantly elevated, it is cholestatic pattern. So we would like to stress that when you are monitoring a patient with tuberculosis treatment, getting just SGPT is not enough. What are the agents implicated in this drug-induced liver injury are the first line ATT, that is H, R, Z, and besides that ethionamide and PS are attributed to cause liver injury. The most toxic of all the agents is believed to be pyrazinamide, and the safest of all this is rifampicin. So pyrazinamide is the most toxic, rifampicin is considered to be the safest of all these three agents. Though there are some belief that rifampicin combined with pyrazinamide may be much more toxic. However, there is no definite evidence for that. So if we see how many people actually develop this acute ATT-induced liver injury, so this is an Indian data coming from South India. So they analyzed 253 patients and nearly 10%. So 1 in 10 develop drug-induced liver injury, which is a big number and which we should not be missing. So if we look at all the drug-induced liver injury, this data was published from our institute in Mumbai, where we saw that 50% of all drug-induced liver injury that we see was caused by anti-tuberculosis treatment. Rifampicin, isoniazid, and pyrazinamide were forming the most common cause of liver injury. So what are the risk factors? Who are likely to develop this ATT-induced hepatotoxicity, ATT-induced hepatitis? So if you are elderly, more than 35 years of age, male, malnourished, who has been suffering from other liver disease, mainly alcohol, hepatitis B, hepatitis C, there is a belief that daily dose might lead to more toxicity as compared to intermittent doses or genetic polymorphism. So I'll give you an example. When we see a 40, 50-year male who is drinking alcohol, who is sarcopenic, who is losing his muscle mass, and who presents with cough, and we diagnose them to be pulmonary tuberculosis, these are the likely individuals who suffer drug-induced liver injury from ATT, and we need to be aware of it. There was some saying that there are people who develop ATT-induced hepatotoxicity, they have higher level of the drugs. So there was a study which actually proved that it is not the drug levels that leads to development of ATT-induced hepatotoxicity. So when they compare individuals with hepatotoxicity with those who did not develop hepatotoxicity, there was no difference in the level of the drugs. How do these patients present? So most common presentation is just asymptomatic elevation in aminotransperases. So nearly 1 in 5 individuals whom we start ATT would develop some rise in the aminotransperases, and actually clinical hepatitis would develop in just near 1 to 6%. So how do we grade this injury? So we follow International Daily Expert Working Group definition, the bottom one. So anybody whom we start ATT, if ALT rises more than 5 times the upper limit of normal, we consider 40 as the upper limit of normal. So more than 200 when the SGPT or ALT rises, that we call it as mild injury, but there should be no rise in bilirubin. Once the bilirubin rises or there is developments of symptoms or symptomatic hepatitis, it is a moderate grade of injury. When they start developing complications of this liver injury in form of ascites, encephalopathy, liver failure, then coagulopathy, then we call it as severe ATT-induced liver injury. And that may lead to death or those who require liver transplant is considered to be grade 4. A lot of individuals who actually present with drug-induced liver injury fail to recover even after stopping the ATT because of the ongoing massive necrosis. They collapse, and over a period of 4 to 6 weeks, they develop encephalopathy and they do not survive unless they are transplanted. So this is one of the very common reasons of developing drug-induced liver failure in India. So what is the timing of development of this injury? So usually this ATT-induced hepatitis occurs only in the first few weeks of starting the ATT. So this is the data published from the United Kingdom. So 53% develop hepatitis within the first 14 days. 72% of all patients develop within the first 1 month. And within the first 2 months, nearly 90% develop ATT. So all those who develop ATT-induced hepatitis tend to develop within the first 2 months of starting ATT. And that is the time when we should be monitoring maximum. How to diagnose it? I think anybody whom we start ATT, before starting ATT, we have already monitored, but when they come with enzyme elevation, we need to ask for any herbal and dietary supplements. I think it is very common in India to start adding various complementary and alternative medicines, unlicensed products as herbal and dietary supplements, and that may lead to rise in elevation. It may not be just the ATT. So we need to take that history, then we need to define the type of injury. And once we know that it is hepatocellular injury, before labeling it to be hepatocellular injury, we need to rule out other causes. Because a person taking ATT is not immune to hepatitis E or A or reactivation of hepatitis B. So anybody who develops a rise in enzymes after starting ATT, this all causes should be ruled out. We should be asking about the alcohol history. We should be ruling out all the viral etiology. And once it turns out to be negative, we label it as ATT-induced hepatitis. So how do we monitor these patients? All patients whom anti-tuberculosis treatment is started, before starting anti-tuberculosis treatment, we tend to get a liver function test, not just the SGPT, a complete liver function test, including the SGPT, SGOT, that is ALT, AST, alkaline phosphatase, GGT, INR, albumin, and even we tend to get an ultrasound abdomen. Ultrasound abdomen in this cases would not just help us to find out if there is an abdominal involvement of tuberculosis or not, but would also let us know about the liver. Because a lot of individuals would have fatty liver and would have low-grade liver injury in these patients. And once they develop ATT-induced hepatitis, their outcome is very poor, because then they classify into acute and chronic liver failure, and then they tend to deteriorate very badly. So an ultrasound and LFT before starting ATT should be carried out in all individuals. Once we start ATT, every 2 weeks, we should be carrying out liver test for the first 2 months. As we saw that most of the time, the liver injury occurs within the first 2 months. So every 2 weeks, we should be calling these patients and monitoring a liver function test. And after 2 months, even then, we should be calling them for a monthly LFT till the treatment is over. When we start anti-tuberculosis treatment, we should tell them, let them know that there are chances that they may develop, because 1 in 10 individuals would develop ATT-induced hepatitis. Then we should let them know, and a written instruction should be given that once they start developing any of these symptoms, they need to come back to us. And again, before starting ATT, hepatitis B and hepatitis C should be ruled out. So once they develop anti-tuberculosis treatment-related hepatotoxicity, I think the best treatment is to stop all the hepatotoxic drug, shift them to hepatosaf ATT. Most of the time, it is ethambutol, streptomycin, amikacin, and fluoroquinolones. And once their enzymes come down to less than 2 times of normal, that is the time when we reintroduce ATT. So there are different guidelines, different recommendations by different societies on how to reintroduce ATT in these individuals. So American Thoracic Society tells us that we should introduce full dose of rifampicin first, followed by isoniazid and followed by pyrazinamide. So we all know that rifampicin is the most preferred drug, and rifampicin, as we said, is the least hepatotoxic. So they consider introducing rifampicin at the earliest. The British Thoracic Society is completely opposite of it. They say that all drugs should be started at the same time, but we should be starting at a lower dose and then gradually build up the dose, monitoring the liver function test. So the Indian group, they carried out a study. They said that let's carry out a study, and they compared the American ATS guidelines, BTS guidelines, and the Indian guidelines, where they said that all drugs to be introduced full doses simultaneously together. And then they found out that there is no difference between any of the regimen that you follow. So we should all follow what we are most comfortable with. And even then, full doses of all the drugs to be started simultaneously become norm, and while monitoring the LFT has been recommended by Indian. What we tend to do is, we usually, if the ATT-induced hepatitis is moderate or severe, we don't introduce pyrazinamide in these individuals. We give pyrazinamide-free regimen. So for a normal liver, if the liver underlying is normal, we tend to give HRE for 9 months. But if if the patient is found out to have underlying compensated cirrhosis, then the regimen that we give is rifampicin, ethambutol, quinolone with cycloserine. If the patient has developed decompensated cirrhosis, ascites, or all those symptoms have developed, then we give ethambutol, quinolone, cycloserine plus minus aminoglycoside based on the preference. I would just like request everyone to mute their audio and so that there's no disturbance for the other audiences. Can we prevent ATT-induced hepatitis? I think I have not seen anybody being prescribed, I would say, N-acetylcysteine over here. But there is enough data, enough recommendation that N-acetylcysteine can prevent antituberculosis-induced hepatotoxicity. So I'll go through this study where 82 individuals were given N-acetylcysteine 600 milligrams twice a day tablet, and compared to 297 individuals who did not receive N-acetylcysteine. And 13% developed hepatotoxicity as compared to 25% in patients not receiving the therapy. And even the duration of developing hepatotoxicity was quite delayed as compared to those not taking the treatment. So is there a prophylactic use of hepatoprotectants necessary in antituberculosis treatment? Published in 2017, a meta-analysis which said that, which included 6 trials with 1,200, more than 1,200 patients. And they said that hepatoprotectants significantly decrease the cases of drug-induced liver injury caused by ATT. Again, a review article which published this year itself said that N-acetylcysteine in the treatment of tuberculosis, though it has included 2 in vivo studies in rats and 1 in vitro study and 1 actual clinical trial where the dose was given as 600 milligrams twice a day, and they concluded that N-acetylcysteine appears to have various beneficial effects on tuberculosis treatment, and there is favorable interaction between N-acetylcysteine and the first-line anti-tuberculosis treatment. However, between the second-line treatment and the N-acetylcysteine is not known, but for all patients, high-risk patients. So I would recommend that patients who are malnourished, who are having a history of alcohol, elderly males developing tuberculosis, there is nothing wrong in adding N-acetylcysteine 600 milligram twice a day to prevent ATT-induced hepatitis. So we have moved on from second topic to the third topic, is those who are actually already suffering from liver disease. Can they develop tuberculosis, and how different is this tuberculosis in the patients who are suffering from liver disease? So this is the third topic. So if we look at all the cirrhotic patients, so if we take 1,000 cirrhotic patients, the prevalence is 73, which is quite high and very high mortality, but most of these individuals are male. So if you look at the Indian data published in 2010, if the individual has history of alcohol related cirrhosis, their tendency to develop tuberculosis is quite high as compared to other etiology. The data is similar from other countries, from Taiwan, from Nepal, as well as Denmark, which show quite high incidence of tuberculosis in patients. This is a Taiwanese study when they saw that when the cirrhotic patients are monitored or observed for a period of 122 months, see the difference between cirrhotic patients and non-cirrhotic patients. There is significant rise in the amount of patients having tuberculosis. Once they develop tuberculosis, their outcome is not good. The mortality is quite high. So if we look at the Japanese data, 18 out of 44 patients died, and in US data as well, the hazard ratios are significantly higher at all period after being diagnosed with tuberculosis in patients with cirrhosis. So cirrhotic patients have more chance of developing tuberculosis, as well as they have higher mortality. So what is the difference in the site of development of tuberculosis? So if we see the site of development of tuberculosis, it is mainly pulmonary, second is pleural effusion, third is peritoneal, and then it can be nodes, it can be liver, intestine, or vertebra, or disseminated. So there are two studies published both from India, 2010 and 2015, showing that pulmonary TB and extrapulmonary TB being the cause. So if we look back at 2007 data, when they compared patients of cirrhosis or with patients without cirrhosis, though pulmonary TB remains the most common site for development of tuberculosis in but extrapulmonary tuberculosis rises significantly in patients with cirrhosis. So anybody with cirrhosis, you should not just assume that they would develop pulmonary. There are more chances that they would develop an extrapulmonary tuberculosis. How do they present? Again, the presentation is no different. Fever, weight loss, anorexia. The most important part is increasing ascites, not responding to diuretics. I think this is very important. When we come across a patient with cirrhosis who has ascites, they are on high dose of diuretics. And when they are not responding to diuretics, people tend to go on to higher and higher dose of diuretics till they develop kidney injury. But one of the reasons they don't respond to good treatment would be development of tuberculosis. That we should all keep in mind, that a person who was actually responding to diuretic treatment, when suddenly stops responding to diuretic treatment, we should rule out tuberculosis in these individuals. The most difficult part of tuberculosis and cirrhosis is diagnosis. I think what we see is we tend to have to repeat the test 2 times, 3 times, sometimes even 5 times to actually document tuberculosis and cirrhosis. The reason is impaired immunity, a false negative test. And all the symptoms of tuberculosis are actually the symptoms of liver disease as well. So low-grade fever, muscle loss, loss of appetite are routinely seen in all patients of tuberculosis as well as cirrhosis. So to consider TB is not easy. How do we diagnose? A chest X-ray or an HRCT thorax or a bronchoscopy or a pleural fluid analysis for patients when we are suspecting a pulmonary tuberculosis. But when we are suspecting an abdominal tuberculosis, it is ascitic fluid analysis, CT abdomen, IVO with oral contrast, not a plain CT, a colonoscopy when intestinal thickening is noted, US guided biopsy when multiple periportal nodes are there, and sometimes a laparoscopy. I would just give you a caution that any patient with cirrhosis with ascites would have a diffuse appearance of thickening of intestine or a colon on a CT scan because of hypoproteinemia. But when there is asymmetric thickening or a localized thickening, then they need to be excluded. The TB needs to be excluded, because symmetric thickening would be a sign of hypoalbuminemia. Asymmetric thickening with all the symptoms, we should rule out tuberculosis. When we do an ascitic fluid analysis, most of the time people just tend to do cell count and a protein. But I would say that when you are doing a test for an ascitic fluid, at least for the first time, get all these tests, and when it is a high protein ascites, go for a further investigation and even repeated investigation whether it is a tuberculosis or not. So cell count, a differential count, lymphocytic predominant should alert us that it should be a partially treated SBP or the tuberculosis. High protein, high albumin, SARC should be calculated, and for tuberculosis, adenosine deaminase, AFB staining, AFB culture, and AFB gene expert is routinely performed at our center when we tap the ascites for the first time. So why ascitic fluid analysis is still confusing for all of us is, I'll go through all the data. So back 30 years back, it has been published that in cirrhotic patients, tuberculosis, peritonitis can simulate ascites from liver disease or SBP. And the ascitic fluid may not be exudative. At that time, SAG was not that prevalent, and it is difficult to diagnose. 2009, they said that this study says, when should we suspect tuberculosis? So whenever there is any extraperitoneal tuberculosis already known, when it is a gradually progressive ascites, not significant ascites, not massive ascites, just mild to a moderate ascites, or a CTPB or a progressed liver disease, lower white blood cell around 600, 700 cells with more amount of lymphocytes and higher protein content into the ascitic fluid and higher ADA, we should suspect tuberculosis in these individuals. So just a study where they have said, published, so how do you differentiate tuberculosis and spontaneous bacterial peritonitis, which is common in all our patients with end-stage liver disease. So the gross appearance is confusing. They both have total protein higher amount. They're both SAG may be low because of significant low albumin. They have LDH elevated. They have glucose decreased. Their cell counts will be more than 250. So there is nothing other than an ADA to help differentiate tuberculosis and SBP. So how important is ADA in this individual? So if we see in a non-cirrhotic individuals, the sensitivity and specificity of ADA in picking up tuberculous peritonitis is significantly high and extremely good. But when we talk about patients with cirrhosis, this dramatically worsens. So in a case of TB peritonitis, in the setting of cirrhosis, ADA activity determination result in 70% of false negative reasons. So in spite of having tuberculous peritonitis, if we measure the ADA, there is only 30% of the chance that we would be actually diagnosed tuberculosis on the basis of ADA. And sometimes malignancy related ascites and SBP can yield mildly false positive results. However, if we look at this data, if the ADA is more than 30, this is highly suggestive of tuberculosis. So mild elevation of ADA would be there, but the cutoff is slightly lower. So they have taken a cutoff, routine cutoff is usually 40, but when they took a cutoff of 30, all the patients of TB peritonitis, only TB had elevated ADA. But just a word of caution that lymphoma and ovarian cancer might cause ADA more than 40. This is for general population. Coming to gene expert, I think not a lot of individuals are known to use this test. So what is gene expert is actually cartridge-based nucleic acid amplification test, PCR, with which we detect the TB bacilli DNA from the ascitic fluid. It is now quite prevalent, easily done, carried out at most of the laboratories. So when you are tapping an ascitic fluid and it appears to have high protein and high cellular count, we would request you to send AFB gene expert for these individuals as well. So if we look at the data from India, the specificity of gene expert is 100%. Though the sensitivity is low, 60%, and accuracy is nearly 70%, but the specificity is 100%. So if gene expert is positive, it is because of tuberculosis, because it is actually detecting a PCR base or TB bacilli into the fluid as well as into the colonic ulcers. So even if there is a colonic or ileocolonic ulcers, I think most of the gastroenterologists do take a sample for gene expert, though the sensitivity is just 32%, but I would recommend that the specificity is 100%. So if it is positive, it is tuberculosis. If it is negative, there are still chances that you may miss. So negative predictive value is just 46%. So you might have missed, but if it is a positive, the positive predictive value is 100%, and that should be taken into account. If you look at the pleural fluid report, so this is a Cochrane analysis of a pleural fluid patients overall in cirrhotic, non-cirrhotic, everybody is included. The specificity is 99% even in pleural fluid, and sensitivity is 50%. Just to look at the studies, the sensitivities can be as low to as high from 10% to 90%. But if you look at all the studies, the specificity is above 95%. So gene expert positive is to be considered tuberculosis from whichever the sample, peritoneal biopsy, ascitic fluid, the ileocolonic ulcer biopsy, or pleural fluid, it has to be considered as tuberculosis. The other important part is imaging. So as I discussed that when a patient develops ascites, they tend to have bowel wall edema, and bowel wall edema can give you a false appearance of tuberculosis like intestine. But if it is diffuse, we ignore it. But if it is asymmetric, we have to do a colonoscopy. Imaging, one of the important feature is CT scan. If we see, look at this image, a person is having ascites, but if we see the enhancing membrane, peritoneal membrane, so this is a sign of infective ascites. So in this case, we should suspect tuberculosis and get the ascitic fluid tested for tuberculosis. The other very routinely performed procedure, I think worldwide and our center as well, is endoscopic ultrasound guided lymph node biopsy. So when we notice there are a lot of peripancreatic, periportal lymph nodes mentioned on ultrasound or a CT scan, we do an endoscopic ultrasound, we take a biopsy and send it for AFB as well as gene expert as well as AFB culture. We do the cytology as well, look for AFB. Finally, if we are still not able to pick up tuberculosis in these individuals, then we carry out laparoscopy and laparoscopic biopsy for this individual. So you can see beautiful white tubercles, or there may be adhesions, and there are granulomas from the histology can be picked up. There are recommendations, and there are a lot of people who come and ask about, can I get a TB gold, can I get a Mantoux test done? So if we see in these individuals, the chances of an indeterminate IGRA or interferon-gamma release assays is very high, and we do not routinely recommend in peri-transplant period because of the lack of access. We do not know what is the role of gold in these individuals. Just request to mute all audios, please. So if IGR is possible, you know what to do with it. So there was data published from Dr. Rella's institute where they found out that 8 patients with IGRA positive, they went ahead with liver transplant, but none of them actually developed tuberculosis after liver transplant. So we do not know the importance of IGRA and we do not recommend it. Similarly, with tuberculin skin test, this is a study where they carried out, no outcome could be appreciated from in a cirrhotic patient with a Mantoux test or a tuberculin skin test. We do not have any idea how to interpret it. Coming to the management of tuberculosis in patients with liver disease, this slide would tell us the window that we have. So a normal person, when we give ATT and they develop deterioration in liver function, there is quite a long window where we can actually recover the liver functions. When a person with compensated liver disease, who is actually cirrhotic, but there is no evidence, radiological evidence of cirrhosis, and they take ATT, and when they develop hepatitis, there is a smaller window to develop to make them recover. There is a smaller window. But a person who is an end-stage liver disease, who is having ascites, who is having low albumin, who is coagulopathy, who is having jaundice, when we give ATT and they develop ATT-induced hepatitis, there is no window from recovery and they would eventually die. So the importance of giving ATT in these individuals, we need to make sure that they do not develop ATT-induced hepatitis. And I think there is not enough data or not enough studies carried out and how to proceed with these individuals. But this is the guideline I think most of the hepatologists and liver transplant centers would follow, is a person with CTP-A cirrhosis. So I don't know if everybody would be using a CTP score, but CTP score is routinely calculated in all patients with cirrhosis, and the things that we include are very easily available. It is bilirubin, albumin, INR, presence of ascites or encephalopathy. On basis of this score, we calculate whether the patient has CTP score A, B, or C. So if the patient has CTP score A, then we tend to avoid pyrazinamide in this individual. So pyrazinamide is avoided in all cirrhotic patients. But if it is a stable liver disease, no complication, then rifampicin and isoniazid can be given. If the CTP score is from 8 to 10 or CTP-B, we have to give either isoniazid or rifampicin, not both. We only give one hepatotoxic agent. And when the patient is very end-stage liver disease or CTP-C, we cannot give any hepatotoxic agent. So the regimen that are used are mentioned below. So if a patient is having a CTP-A cirrhosis, a compensated cirrhosis, we need to document. If a patient is having a compensated cirrhosis, then we avoid pyrazinamide, give HRE for 2 months and HR for 7 months. If the patient has CTB cirrhosis, we give either of H or R along with ethambutol and quinolone. Cycloserine may be added based on after discussion with our TB specialist and ID specialist, and the regimen is given for 12 to 18 months. If the patient has CTP-C cirrhosis, it is ethambutol, quinolone plus minus cycloserine. One thing I would like to stress here is we have not mentioned streptomycin or amikacin. Though it is routinely used in non-cirrhotic patients, we are quite scared by using aminoglycosides in these patients because if they develop nephrotoxicity and acute kidney injury, the patients of cirrhosis tend to develop multi-organ failure, and so we are quite skeptical in using aminoglycosides in end-stage cirrhotic patients. So coming to the last part of my talk, and that is tuberculosis in patients of liver transplant. Just few slides. I will not go into detail about it because I know not many would be dealing with liver transplant patients. But the three things that we consider is pre-transplant evaluation, drug interactions, and drug-induced liver injury post-transplant. So anybody who is undergoing a liver transplant, all patients of undergoing liver transplant has to undergo an HRCT thorax to rule out an active pulmonary tuberculosis. Pleural effusion. Now all patients of cirrhosis would tend to have some amount of ascites, and when they tend to have ascites, they tend to have some amount of hepatic hydrothorax or pleural effusion. Now it is an isolated minimal right-sided pleural effusion. We don't do a pleural tap. But when there is moderate amount of pleural effusion on the left side more than the right side, or isolated left-sided pleural effusion, we go ahead and get a pleural tap done. It is very risky because of the coagulopathy. Patient has INR remains 4 or 5, patient has bilirubin of 10 or 15, they have very poor albumin, very sarcopenic, so there are a lot of chances of bleeding. So we do not routinely recommend pleural tap in these individuals, but when we are suspecting tuberculosis, we go ahead and get a pleural tap done, and we have picked up at least 5 or 6 patients of tuberculosis with pleural tap in these individuals, and we have even sometimes diagnosed tuberculosis with bronchoscopy in these patients. And this is thanks to our excellent pulmonology team who are quite aggressive to diagnose tuberculosis in these patients. Role of IGRA or TB Gold and Mantoux test or tuberculin is not there in India, at least in Indian patients, though it is routinely recommended in Western countries. At our center and a lot of centers in India have stopped doing these tests. Why we need to know post-transplant patients as tuberculosis? Because if you have undergone liver transplant, any patient would be on any of these immunosuppressants. So cyclosporin, tacrolimus, mycophenolate. Most of our patients would be on tacrolimus and mycophenolate mofetil after transplant. And 2 years, 3 years, or 4 years after transplant, if they tend to develop pulmonary tuberculosis, which is the most common tuberculosis after post liver transplant, if we give anti-tuberculous treatment containing rifampicin, then they can lead to liver graft rejection, because rifampicin is an enzyme inducer. And once we give rifampicin, the levels of immunosuppressions go down significantly. So anybody with liver transplant after liver transplant developing pulmonary tuberculosis should not be just routinely given full dose ATT. So what the guidelines recommend is, if it is a non-severe form of TB, we avoid rifampicin based therapy. But if it's a severe form of tuberculosis or disseminated tuberculosis, we include rifampicin, but we need strict monitoring of all the immunosuppressants at a transplant center. And the tacrolimus and the sirolimus and all their doses needs to be increased 3 to 5 times under strict monitoring. So tuberculosis should not be routinely treated with full drug ATT without monitoring in patients of post-transplant. And there are guidelines available, published 10 years back for this. Coming to, can a patient with tuberculosis be transplanted if they need a liver transplant? So yes, they can be transplanted if they need a liver transplant. So if a person with active sputum positive pulmonary tuberculosis needs a liver transplant, normally we tend to wait till the sputum becomes negative and we tend to transplant these individuals. So this is a data published from India where they have looked at, not from India. So where they have transplanted patients with tuberculosis. So if we see the TB location, mainly there was 70% had pulmonary tuberculosis, and diagnosis of TB pre-transplant was done in 50%, while post-transplant was done in nearly 50%. Just look at the data. Mainly they were the viral hepatitis. They all were able to give rifampicin-based therapy, and this was the immunosuppression. I would not go into the detail. Most of them had pulmonary tuberculosis, and ACR stands for acute cellular rejection. So keep in mind, once you give rifaximin-based therapy in this patient, there is high chance of development of cellular rejection in this patient, and they need to be monitored. However, giving an ATT is possible and successful in this patient, and patient do survive even after they develop tuberculosis in this patient. So to finish off my talk, I think isolated liver tuberculosis is quite rare. ATT, drug-induced liver injury, is quite common. We should all be aware of it. So when we are giving tuberculosis treatment, we need to understand if we can give N-acetylcysteine in these patients or not, and strictly monitor it. Not all ascites in cirrhosis is cirrhotic ascites. TB ascites and TB proliferation is quite common. It is very difficult to diagnose. We need to repeat the test, keep on repeating the test if we are suspecting, and we need to know which drugs which can be given and which cannot be given. And TB can be managed peri-transplant, and there is no worry. If the patient requires transplant with tuberculosis, they should not be denied a transplant. I would thank the institutes for the training that I have received, and I would thank all my mentors for making me reach where I am today. So I end my talk.